giving you the countdown. We are live in 5, 4, 3, 2, 1. We are live now.
Thank you, OrthoTV, and thank you, APSS Secretariat, for organizing this wonderful webinar on Advanced Spine webinar series. So just to bring to you the highlight, this is the first APSS Advanced Spine webinar series in the year of 2023. After a big leap from 2022, where we did many such advanced webinars on scoliosis, kyphosis, and spinal deformity, other aspects. This is just a beginning of another series of advanced spine webinars under the aegis of Asia Pacific Spine Society. And I take this honor to welcome all the August faculty members who are joining us from various parts of the Asia Pacific continent. I take this honor to welcome Dr. Sejun Park from Korea. Welcome, Dr. Sejun. I take this honor to welcome Dr. Chris Chen from Malaysia, Dr. Arvind Kulkarni, my senior colleague from India, Dr. Pang Wu from Singapore, and Dr. Young from Malaysia. I also take this honor to invite the moderators of this session, Dr. Pang Wu and Dr. Vijay Loya, who will be moderating this session on APSS Advanced Spine Webinar Series program. On behalf of the President of Asia Pacific Spine Society, Professor Dr. S. Rajashekharan, who because of some personal reasons couldn't join for this webinar, who will be very soon joining us in a small while, I take this opportunity to welcome all the August members in the delegates who are watching this, who have registered for this APSS First Advanced Spine Series webinar program, the theme of which is minimal invasive spine surgery. We are all aware that the last decade has seen a complete leap in modern advances in technology, and minimal invasive spine surgery techniques have proved the test of time already, also paving the way for future to reduce the morbidity and increase the safety and precision in the results and outcome of spine surgery. With this vision in mind, these 2 hours are going to be deliberating upon minimal invasive spine surgery with the who's who of spine surgeons world in Asia Pacific continent being around, deliberating upon various topics, techniques, and also problems and solving methods, along with case discussion forum. Mind you, this is an interactive case discussion based situation where you are allowed to put in your questions in the chat box, which will be directed to the speakers via moderators of the session, and we'll be more than happy to bring forward further answers to all the questions coming ahead. With this, without much ado, I take this opportunity to welcome you all the delegates, and I really wish and hope a wishful learning of next 120 minutes in presence of these August faculty members from Asia Pacific. May I hand over the proceedings to Dr. Wu, the moderator for the day, and Dr. Loya, the moderator for this session. Dr. Wu and Dr. Loya, over to you.
Thank you, Dr. Vishal and Dr. Loya. Maybe I will start with the introduction of Dr. Park. Dr. Sejun Park is a well-known international, well-known expert in oblique lecture, lumbar interbody fusion of lower lumbar and lumbosacral spine, as well as extension to various techniques in deformity. Let's welcome Dr. Park to deliver his lecture.
Hello, this is Sejun Park from Korea. It's my great honor to present my lecture in APSS webinar. I'm going to talk about oblique lumbar interbody fusion and lower lumbar and lumbosacral spine. Today, I will discuss about the advantage of OLIF surgical approach and its application to other spinal deformity surgery. We have several techniques for lumbar interbody fusion. According to direction of approach, lumbar interbody fusion are named as posterior lumbar interbody fusion, transforaminal interbody fusion, anterior lumbar interbody fusion, direct lateral interbody fusion, and oblique lumbar interbody fusion. The direction of OLIF is oblique way, and its surgical corridor is located at anterior to psoas muscle. OLIF has several advantages. In my opinion, the biggest advantage of OLIF is less bleeding. We can also expect indirect neural decompression. In addition, because OLIF use larger and higher cages, it is very effective to increase fusion rate and restore the segmental lordosis. Considering bleeding source during conventional posterior surgery, we can minimize epidural bleeding because OLIF cage is inserted laterally through avascular structures. We can also minimize bone bleeding because of less requirement for direct laminectomy and sometimes less need for 3-column osteotomy. Indirect decompression is one of the big advantages of OLIF surgery. It uses ligamentoctaxis principle. Disc space distraction induces unbuckling of annulus fibrosus and yellow ligament. Then central canal stenosis can be decompressed without laminectomy. It is best indicated for mild to moderate central stenosis. Foraminal stenosis is also best indication of indirect decompression. In most foraminal stenosis cases, such as spondylolytic spondylolisthesis, nerve root is compressed with disc space collapse. Therefore, just distracting disc space can make indirect foraminal decompression without direct foraminotomy. For performing OLIF 2.5, patients are positioned in true lateral position. Left approach is preferred because aorta is located at left side, which is more safe than inferior vena cava. Its surgical corridor is between psoas muscle and aorta, therefore, it can be safely performed with regard to lumbar plexus injury. After making small incision, 3 muscle layers of abdominal wall, external oblique muscle, and internal oblique muscle, and transverse abdominal muscle is splitted along their muscle fiber. Then you can see retroperitoneal fat. After gentle retraction of abdominal content to anterior side, you can identify the psoas muscle. Sometimes you can meet ureter and sympathetic chains anterior to psoas muscle. After checking proper level, discectomy is performed and cage inserted using orthogonal maneuver like this figure. OLIF 5.1 is the same corridor as conventional OLIF, which is between both iliac vessels. However, OLIF can be performed in lateral position like OLIF 2.5 technique. Therefore, if you plan multi-level OLIF surgery, you can perform OLIF 5.1 and OLIF 2.5 together without changing the patient position. OLIF 5.1 starts with skin marking using vertical line from sacral posterior corner and parallel line to L5S1 disc space. The incision site is about 2 finger breadth anterior from ASIS. Like OLIF 2.5, 3 muscle layers should be dissected. However, in this area, external oblique muscle is seen as aponeurosis rather than muscle fiber. With a blunt dissection using sponge forceps, you can enter retroperitoneal area and you will identify L5S1 disc space between both iliac vessels. Then self-rejectors are placed like in this figure. After total discectomy, trial was performed in oblique direction and the cage was also inserted in the same direction. Preoperatively, L5S1 disc space looks very collapsed and segmental lordosis was decreased. Postoperatively, you can see disc space was well restored with increase of segmental angle. OLIF surgery is very effective tool for adult spinal deformity surgery. We have 2 kinds of methods to correct adult spinal deformity using OLIF surgery according to posterior fixation techniques. If we perform percutaneous pedicle screw fixation after OLIF, we call it circumferential MIS technique, which is CMIS. If we perform posterior open screw fixation with punctal osteotomy, we call it hybrid technique. Percutaneous fixation can be performed using multi-level short skin incision and fascia incision. If we extend S1 incision more distally, we can insert iliac screw through this incision. And if we want posterior fusion in thoracic spine area, you can add a selective open pedicle screw fixation in this area. By percutaneous fixation, you can significantly minimize muscle damage and blood loss. However, like in this figure, it is very difficult to add more lumbar lordosis. Therefore, percutaneous fixation should be considered as in situ fixation principle. If we want more lordosis, you have to consider open fixation with multi-level facetectomy or ponte osteotomy. This lady presented with severe rotating pain with claudication less than 3 minutes. On X-ray and MRI, she had kyphoscoliosis in lumbar spine and foraminal stenosis at left L3445 and right L5S1 levels. Staged surgery was performed. First, I performed OLIF from L2 to L5 through one incision and OLIF L5S1 through separate incision. After inserting KG, the neural foramen was decompressed indirectly. However, it still looks stenotic at left L45 and 34 levels. I performed open fixation with multi-level ponte osteotomy, and I did selective foraminotomy only at left L34 and L45 levels. After surgery, her deformity was well corrected and symptom was dramatically improved. With OLIF surgery, we can minimize bleeding loss. Therefore, we could perform this kind of big surgery using just 2-level hemilaminectomy. This 77-year-old female presented with back pain with both leg rotating pain. She also complained with severe stooping, like in this figure, so she could walk less than 5 minutes without break. The problem is that she has multiple comorbidities such as DM, CRF, and angina. In this case, we consider the technique to reduce intraoperative and postoperative bleeding as much as possible. On her MRI, central stenosis and neuroforaminal stenosis was seen at L45 levels. However, the other levels did not have significant stenotic lesions. So I performed one-stage OLIF surgery from L2 to S1. I expect indirect decompression at L45 level, so I did not perform posterior laminectomy. Her total blood loss was only 550 mm, and 1 pack of RBC was transfused for her. After surgery, her sagittal imbalance was markedly improved, and she can walk 30 minutes without break. In summary, OLIF has several advantages such as less bleeding and indirect decompression. Indirect decompression is best indicated for mild to moderate central stenosis and foraminal stenosis caused by disc space collapse. OLIF is very useful for multi-level fusion for adult spinal deformity. It has good correction power for coronal and sagittal deformity. You can choose percutaneous fixation or open screw fixation technique. If the lordosis was properly restored just by inserting KG, you can perform circumferential MIS. However, when you need more lumbar lordosis, you have to consider hybrid technique with open screw fixation and ponte osteotomy. Thank you for your attention.
Thank you, Dr. Park, for the wonderful lecture. Let's see.
Thank you.
Yes. So there's a question in the chat box. Thank you. For OLIF in trauma patients, what are the challenges? Are they different from degenerative cases?
Yeah, thank you. Thank you for your question. Actually, the OLIF surgery is best indicator for degenerative cases. So recently, I don't have much patient treated by OLIF with because of trauma. So actually, it's I think the same philosophy as degenerative cases, but the usually lateral surgery is indicated in trauma patient such as corpectomy. Or so I think the principle is the same as degenerative case with a fracture case. I didn't have much experience about the fracture cases.
Thank you so much, Dr. Park. And then there's another question. In terms of bleeding, is there an additional problem or complications for OLIF compared to XLIF? And that leads to the second question by Dr. Chikit. What the advantage and disadvantage of OLIF compared to XLIF or lateral lumbar interbody fusion?
Thank you for a nice question. Actually, bleeding is a big barrier for the patients, such as using PLIF or conventional open technique. OLIF is a very effective tool to reduce blood loss because we don't have to encounter epidural bleeding during cage insertion. So OLIF is the best way to reduce the bleeding. And comparing the XLIF or DLIF, it's the same procedure. However, XLIF and conventional DLIF procedure goes into the psoas muscle. So you have to consider the neural monitoring. However, all the procedure, you can insert cage anterior to psoas muscle. So you don't need to prepare the neural monitoring. In terms of neurologic deficit, all is more safe than conventional XLIF or DLIF surgery.
And in another question by Dr. Vishal, in the degenerative scoliosis, is OLIF approach from the convex side or the concave side? Which side do you choose?
Okay, very good question. In degenerative scoliosis, it is more efficient to go into the concave side, because the concave side you have to make a small incision. In small incision, you can go to the multiple site. However, in my experience, I prefer always a left side approach, regardless of concave convex side. So I prefer to go into the left side approach because of the grave vessel injury risk. So I usually prefer left side approach regardless of concave or convex side. However, the incision site is the difference of incision site to concave convex site is not so big. So you can consider the left side approach even in the convex side.
Okay. And Dr. Sudhir asks, have you encountered any approach-related complications in your series?
Yeah, so it is also a very good question. We have several complications related with the approach. First one is you can encounter abdominal pseudohernia. Pseudohernia means the atony of abdominal musculature. So patient suffer from bulging of abdominal wall, and sometimes patients suffer from some dysphagia or tingling and some pain. However, the risk of abdominal pseudohernia is reported at less than 10%. And unfortunately, we don't have any preventive tool to prevent the abdominal pseudohernia. So it is very important to inform the patient that you can have suffer from the abdominal pseudohernia before surgery. And maybe the other rare problem is ureter injury or sympathetic chain injury. Ureter injury is very rare because ureter will be shifted anteriorly with the retroperitoneal fat. So, however, sympathetic chain injury is more common. Sympathetic chain is lied in the within the corridor of OLIF surgery. So it can be injured during surgery. However, if sympathetic chain injured, the patient may feel some different temperature on her on patient's lower extremity. However, there is no significant sequelae, so the temperature will be normal in some days or in some weeks. So you don't have much worry about that.
personally, I felt that maybe avoiding use of diatomy can, I mean, that's my own opinion, can prevent the pseudo hernia. I'm not sure whether it's proven. I think it's difficult to prove that. I use knife for the beginning part, but I don't have much evidence on that. One more question is for severe lumbar canal stenosis, do you rely on indirect decompression or do a direct decompression prophylactically? How do you decide on this, Dr. Park?
So it is a very critical question. So indirect decompression, the principle is a ligamentathesis by the unbuckle of the second ligament problem. However, in severe central stenosis, I'm worried about the effect of indirect decompression. So in my personal experience, I always perform direct laminectomy in case of severe central stenosis. However, the other surgeons believe that the indirect decompression, even in the severe central stenosis, the principle is to reduce the dynamic portion of the stenotic lesion. So if you eliminate the dynamic portion in stenotic lesion, the pain can be improved without direct decompression. And more importantly, in longer follow-up, the second ligament problem will be become very thin without direct decompression. So it is very controversial. However, in my experience, I prefer direct decompression in severe central stenosis.
Do you stage your procedure to see whether the patient felt better after the OLIF cages, then decide the posterior decompression, or you go straight ahead in the single setting, turn the patient prone and decompress the posterior lamina?
So you mean stage surgery?
Yeah, to see whether you need to decompress or you just straight away decide to decompress.
So it is a very good question. However, I don't like perform stage surgery because it is very difficult to identify the patient improvement actually. So because the patient suffer from operation site pain, and if you allow the patient to walk around to see the pain was gone, the problem is the without fixation, this segment is very unstable. You can encounter some cage subsidence during walking. So I don't prefer the stage surgery to see the patient symptom improvement.
Okay, thank you so much. I think we'll move on to the next speaker. Dr. Vijay will introduce the next speaker. We can address the further questions when I discuss my case later on. We can address more questions on OLIF procedure.
Good afternoon. Now I would like to introduce Dr. Arvind Kulkarni for his talk on minimal invasive treatment, tubular and mini open PLIF and TLIF. Dr. Kulkarni, the stage is yours.
Yeah. Good afternoon, everybody. I thank Dr. Vishal and APSS for inviting me. I would request my video to be played. Thank you. Dear friends and colleagues, it's a matter of pride to make this presentation. I thank Dr. Vishal and APSS for inviting me. So let me start with the sad story of a 60-year-old obese lady with a host of comorbidities, including diabetes, hypertension, renal failure, etc. Poor lady underwent a L4-5 destructive laminectomy for L4-5 stenosis, following which she did not get out of her bed because she was rendered not only unstable, but this wound failed to heal for almost 4 months and healed after plastic intervention with secondary intention. So we had a quick solution for this miserable lady in the form of a minimally invasive TLIF, which came as a boon where the goals of surgery, that is fusion and stabilization, was immediate stabilization with pedicle screws and rods was achieved. using tubular retractors and percutaneous pedicle screws through these tiny wounds shown here. She went home smiling. So the principle behind MIS TLIF is surgical strike, that is precision surgery. The goals of TLIF are to achieve decompression and fusion, which is achieved through these tubular retractors, which are inserted through focal wounds, and immediate stabilization with screws and rods, that is achieved through this small tiny wounds using percutaneous pedicle screw system, instead of exposing this wide as is done in open surgeries. And this obviously has various benefits in terms of wound healing, pain recovery, cosmesis, etc. There is significant data to show that following an open TLIF, the muscles turn into fat, and there is a lot of scar tissue as a result of this reactionary edema in open TLIF as compared to MIS TLIF, where it looks almost untouched. Again, you don't need to learn rocket science here. It is very obvious that the surgical infection following a MIS TLIF would be less compared to open TLIF, obviously because of lesser surface area that is exposed to potential pathogens. A host of indications which increase with experience. This is a common indication. Degenerative listhesis with stenosis is a very tight canal. Spondylolytic listhesis, grade 4, that is high-grade spondylolisthesis with severe lumbosacral kyphosis, which can be tamed using MIS techniques. Spondyloptosis even can be managed with this particular technique. Central disc herniations, multi-level stenosis, large disc herniation, massive disc herniation causing cauda equina, selective fusion in a case of degenerative scoliosis, spondylodiscitis, post-laminectomy instability, where you can avoid the midline scar, and obviously an obese patient where you would refuse to do an open TLIF, and I would insist on a MIS TLIF for my comfort. So TLIF consists of two basic steps, that is decompression and fusion, which in this case is achieved through these tiny incisions using tubular retractors. And the next step is immediate stabilization using percutaneous screws and pedicle screws and rods, that is again achieved through these tiny wounds. The parameters of incision would depend upon the patient, the level operated, and the indication. As I said, two parts of surgery. First part is one part is pedicle screw insertion. There are guidelines and algorithms to pass your guide wires on which the pedicle screws are railroaded, and there are algorithms and again guidelines to pass your rods and techniques of passing these rods. This is one part. Second part is achieving decompression and fusion. There is a difference in the steps when it comes to degenerative listhesis, where you need to decompress the entire canal because the canal is tight, and the steps in lytic listhesis is again different. So how do you achieve in degenerative listhesis? So you insert these tubes on the ipsilateral side of on one side. You generally have hypertrophic facets here as a result of wear and tear. So these are drilled till the level of the lamina. Then you do a facetectomy ipsilaterally. Then you tilt the tube on the opposite side, do a contralateral decompression till you see the root on the opposite side all the way escaping into the foramen. See that the lateral recess is free. Then you tilt the tube again on your side, do a ipsilateral decompression, do a perform a discectomy, pack the anterior 1/3 of the disc space with bone graft, and hammer your pre-sized cage. So this is with regards to degenerative listhesis. And when it comes to lytic listhesis, the pathology is different. It is a dynamic compression as a result of fibrocartilage in the pars that hammers the root. So what you need to do here is jack up the disc space, insert a cage, make it immobile, and then pass your percutaneous pedicle screws and rods. So that is a variance in these two pathologies. So for example, here the you can see the exiting foramen here, the foramen of the exiting root, which is widened. The reason being this disc space, which is flat and collapsed, opens up once you hammer the cage inside. And this is all done through these tiny holes as shown here. Isn't it a wonder? So I'll just show you a video of how it is. This particular procedure is done using C-arm. This is the most commonly done technique, that is with the C-arm. So insertion of Jamshedi into the pedicle, guide wires through the Jamshedi, then the percutaneous pedicle screws on one side, and insert a rod and distract that particular side to open up the disc space. Then go on the contralateral side, use these tubular retractors to achieve your goals of decompression of the exiting root, insertion of the cage, and achieving stabilization with again pedicle screws and rods on the ipsilateral side. This is an excellent technique, but there are issues here. You don't get an axial image, and radiation is obviously a big hazard when it comes to high volume MIS TLIF surgeries using C-arm. So the way out is to use 3D navigation, which helps in minimizing your radiation also, and which also provides you images in all three planes, not just sagittal and coronal, but also in axial plane, which is very, very relevant. So this is a short video of how this is performed using a 3D navigation system. So this is a lytic listhesis. We are getting these images of the patient using an isocentric C-arm, and these images that are available on the monitor are CT images on which one can navigate. So you get images in all planes, as I said, coronal, sagittal and axial. And the instruments that we use to perform this particular procedure, including the Jamshedi, the taps, the screws, are all seen on the screen. They're all navigation compatible. So this is a drill going into L5 and S1 pedicles on the contralateral side, on which the screws are passed. Then you come to the ipsilateral side, insert your tubular retractor, perform your decompression discectomy on the ipsilateral side, reduce the listhesis on the opposite side where you pass your screws, then come back in your bone graft cage, then you pass your pedicle screws. You can see the pedicle screws getting into the vertebral body at L5 and S1, and then you pass your rod. And this is the final picture. So any indication under the sun is an indication for a MIS TLIF. To learn this particular technique, one should hone their skills in using the tubular retractor initially. One should hone their skills in passing percutaneous pedicle screws. Of course, when you're using a C-arm, radiation is the biggest hazard, and one can always protect themselves and increase precision using modern amenities, facilities like navigation, robotics, etc. Thank you very much. I thank APSS again for this particular opportunity.
Thank you, Dr. Kulkarni, for your talk. There's a question in chat. The question is from Dr. Wu Pang. He asks about what is...
Can you hear me?
Oh, I think Dr. Vijay is offline. Maybe I ask the question directly. So what the incidents? I find that for grade 2 and above spondylolisthesis, after doing MIS TLIF, sometimes the screw may back out, and then there's a tendency for the listhesis to go back to where it wants to be. So what are your tricks to keep it maintained at grade 0 and to prevent the screw backing out from the proximal screw specifically?
Yeah. This is an excellent question for people who do MIS TLIF routinely. So here it is all the play of the pedicle screws which decide as to how aggressive you are. So it's very important that your pedicle screws are in place in all dimensions. So you need to put the longest screw. You should push for that. You need to be as medial as possible. You need to put the widest screw that is possible. You should need, in these cases, I take the risk of being bicortical. If you see my X-rays, and usually if you're quite medial, you're usually safe. And again, when it comes to the S, this is with regards to both alpha as well as S1 screw. And S1, in most of these cases, the tip of the tricortical bone is absolutely sclerotic. And it is very, very important that you have a very good purchase in that sclerotic part. The last bit of your S1 purchase has to be excellent if you want to play around and reduce these listhesis. And in ladies, especially osteoporotic ladies, it's very important that you aggressively treat their osteoporosis with basic investigations and medical therapy, and get them on table after at least 2 months of anti-osteoporotic treatment. Don't hurry up. And when it comes to cage, it basically depends on how, you shouldn't be creating craters in the end plates. That is the most important thing. So don't be aggressive with your shavers. Don't be aggressive. So if you try to put a very big cage in a small space, you will get a back out. So be very, very, spend some time on your cage preparation, your disc preparation and your cage insertion. It has to be optimum. It's hard to describe on a presentation, but when you're on the OT table, it should be somewhere between too loose and too tight.
So there's another question in the chat. What is your incidence of adjacent segment disease after MIS TLIF? Does it add any problem to revision surgery?
Yeah. So this is also an excellent question, because after you've done a TLIF at a particular level, it's fair that after a few years, one of these patients might come with pathology at the adjacent level, and they should be geared up for this. And I don't see a high incidence of ASD in my practice. I'm not sure why, but whenever we need to do it, so the thing is, it's quite simple. You can go through the same lateral incisions, extend them a bit. You remove the screws. You pass your guide wires again through those holes. And for example, if you've done a L5 S1 and you need to do L4 5, so you remove the L5 and S1 screws bilaterally. You pass in guide wires through the same holes and rest them, and pass guide wires again at L4 pedicles. Then you do an interbody fusion through one of the holes, and you put all those 6 screws again and a new rod on both sides.
Yes. Thank you, Dr. Kulkarni. There's also another question in high-grade listhesis in elderly female. What is, do you think there is increased implant stress or subsidence or cage migration compared to conventional open cases in the same patient profile?
Yeah, so in high-grade listhesis, you can classify them into 2 kinds of patients. One is where there is significant translation. So this is quite common in elderly ladies. So you get about grade 2 to grade 3, listhesis in this elderly female, but there is not much lumbosacral kyphosis. The patients where you get this lumbosacral kyphosis are usually, adolescents and kids. So there, as it is, these people being kids, they have this set of patients because they are kids. They have good, good bone stock. In elderly patients, as soon as you position them, you will get a degree of 1 degree reduction. And once you play around with the disc space, another degree, and with the pedicle screws, another half degree. So you almost get a complete correction. So as I said previously, you need to see that their osteoporosis is straightened out before these, at least managed well, perioperatively. And you don't push in a big, large cage in a small disc space, because you're going to just vomit out.
Sir, what is your experience for MIS tubular approach for multi-level cases?
Yeah,
How
advanced? Yeah, so that is also an excellent question. It all depends on your patience. So I have patients for maximum 2, and if a patient really pushes me for a 3rd level, but I would love to do just 1 level cases, but it's possible to do 2 to 3 levels.
Any pros and cons compared to open while doing the
Especially,
multi-level cases.
so if you compare a two-level MIS TLIF, for example, L4-5, L5S1, for in an extremely obese lady with a host of comorbidities, I would actually refuse an open TLIF in such a patient. So there are just pros and pros and pros with regards to minimally invasive TLIF in terms of pain, in terms of wound healing, in terms of mobility, etc. But of course, you need to have a certain degree of experience to tackle these cases with MIS.
Thank you, Dr. Kulkarni. That was an excellent talk from your end. Now I would like Dr. Rupang to introduce the third speaker.
Thank you.
Thank you so much. Let's introduce Dr. Christine Wei Chan from Malaysia. He's discussing on minimally invasive treatment of metastatic spinal disease.
Thank you very much, Dr. Wu. Can you hear me?
Yes, I can hear you. Thank you.
You can see the slides?
Yes, I can see.
Okay, thank you to Dr. Vishal and the whole online education team for the invitation to this webinar. It's always a pleasure. So I would like to start my presentation with a case. It's a very common scenario, 67-year-old gentleman, stage 4 lung adenocarcinoma, EGFR positive. As you can see from the CT scan image, there's a left upper lobe lesion.
I can't hear you at the moment.
Can you hear me?
Now I can hear you.
Okay, so the patient complained of instability with bilateral lower limb weakness with a sensory level at T12. And this is due to a MIS TLIF at T10 level. So the axial scan shows a Bielski 2 type compression with an extensive impingement over the spinal cord. And from the CT scan, there's a T10 lytic lesion, there's an ankylosing spine at the adjacent segments, and there's a bilateral pedicle erosion. So patient has severe instability pain, CIN score is 13. And as well from the CT-TAP, there's a multiple liver metastasis. So the diagnosis is a MIS TLIF Bielski 2 T10, secondary to lung adenocarcinoma, EGFR positive. Tomita score is 10, Tokuhashi score is 4, CIN score is 13. So this brings us to the talk of what is the role of minimally invasive treatment for metastatic spinal disease. So we know from the publication by Petchel in 2005 that the surgery is advantageous for patients with MIS TLIF in terms of prolonging their ambulatory status, in terms of maintaining their continence, improvement in Asia score and maintaining the Asia score, Frankel score, as well as in terms of their survival. So what is the rationale, the feasibility, and the results of MIS for MIS TLIF? It is feasible because now we have an evolution of decompression techniques. In traditional surgery, such as in a paper by Petchel, we often discuss and compare between corpectomy versus laminectomy. So at that time, corpectomy was advantageous, and one, because there is a direct decompression when you perform a corpectomy, because the compression is from the front, you decompress from the front, and as a result, there's a less risk of local recurrence with tumor excision. But with the advent of stereotactic body radiotherapy, and now it is quite widely available, there's a paradigm shift in the way we approach decompression. It is able to deliver a very high dose radiation, which is conformal to where the tumor is, and reduce the exposure to the surrounding structure. And this would lead to better local control. So from the traditional surgery, we move on to modern surgery, whereby we're actually comparing corpectomy versus separation surgery. So just for illustration, the red shaded area is how we perform a corpectomy. So we remove almost the entire tumor bulk from the front, whereas in separation surgery, after performing a laminectomy, we perform a direct neural decompression, as shown in the yellow shaded area. And this is a post-op MRI showing after separation surgery, showing the neural decompression. And following that, we would target the residual tumor in front by SBRT, which will give us local control. And secondly, it is more feasible nowadays is because of evolution of percutaneous instrumentation. It is already proven that percutaneous instrumentation to the thoracic spine is safe as well as feasible. And we have even published that the results over the proximal thoracic spine from T1 to T6 is equally safe. And newer instrumentation allow us long segment stabilization, which is important because we're dealing with a pathology which affects multiple levels and very often affects skip levels. And third, MIS is the best indication for MESCC because there's no need for fusion, which is a problem in MIS surgery. So this has moved us to the modern surgery, whereby this is the operative workflow. We can see from the intraoperative image on the left, there's a small decompression wound, separation surgery, followed by percutaneous stabilization. And this gives us advantage in terms of reducing the known complication rates of traditional surgery, which is very high. And in this paper, which was published in 2017, the total complication rate is as high as 27%, wound healing problems 10%, and multiple complications 20%. And why is this important? It is important because the occurrence of complication would delay the administration of the adjunct or adjuvant therapy, and this will lead to local and systemic disease progression. And we look at the evidence for MIS surgery. From Prof. Naresh's paper, it is clearly shown that MIS surgery using a decompression and MIS approach correlates well with a lower invasiveness and therefore lower blood loss and operative time. We have published a result comparing MIS and conventional open surgery for spinal metastasis in a prospective propensity score match study in 2017, which shows that MIS led to lower blood loss, lower transfusion, and shorter hospital stay, as well as less complications in the MIS group. And in this latest systematic review and meta-analysis in 2021, there are 576 patients, 271 MIS, 305 open surgery. This meta-analysis showed there's lower intraoperative blood loss, less transfusion, and decreased odds of complications if we administer an MIS approach. So now let's get familiar with this NORMS framework, which is a very important treatment algorithm for management of metastatic spine disease if we are to incorporate an MIS approach. So let's go back to the case. So the NORMS approach, it stands for neurologic, oncologic, mechanical, and systemic, and this was introduced back then in 2013. For neurologic, it's divided into low grade or high grade, and in our case, which we described earlier, it is a high grade nerve compression, and therefore, next we look at the oncologic. Oncologic, we look at the sensitivity of the tumor to radiotherapy, and in this case, it is a non-small cell lung carcinoma, and it is known that this tumor pathology is unfavorable. And when we combine a high-grade compression with a radio-resistant tumor, then the recommendation for this is separation surgery followed by SRS. So this patient underwent separation surgery. Post-operative MRI shows that there's a good decompression. And as shown here, after separation, there's a space around the nerve which would allow us to administer SBRT. And mechanical, this patient obviously has instability and therefore needs stabilization. So in this patient, he underwent long construct minimally invasive stabilization. Long construct and the longer segment because this patient, as you remember, has ankylosed spine. CT scan shows a good placement of the screw above and below. And at the center, there's a separation surgery. Systemic is whether the patient is able to tolerate surgery, because we still fall back to this very important principle which was mentioned by Professor Tokuhashi, that in the treatment of spinal metastasis, life expectancy is still the most important. And we have relied on historic scoring systems such as the Bauer system in 1985, Tomita scoring, Van der Linden scoring, Tokuhashi, and recent criticism of this scoring in the sense that it is not that accurate has led to introduction of modern scoring system. We have the RAID scoring system, Oswestry Spinal Risk Index, SORG nomogram, and we have a whole lot more of scoring system, but there's a growing consensus that the use of prognostic scoring system nowadays underestimates survival and has become obsolete. And in this review, which was published in Clinical Spine Surgery, the authors mentioned that we should never rely on prognostic scores alone, and it should be an interdisciplinary cooperation of oncologists, radiologists, and spinal surgeons to decide the need for surgery, and besides, the individual intention should be respected. And therefore, how do we decide whether patient is able to tolerate surgery in our center? If only if the patient has very severe end organ mets, such as extensive liver mets, brain mets, or extensive lung mets, and the patient must have more than 3 months survival. And of course, we consult our oncologist colleague. Then we decide together as to whether the patient can undergo the surgery. So what are the pitfalls? Number one, early implant failure, such as in this case, which is shown that from the CT scan that the screw back out about a month after surgery. Why is that so? Because number one, we're dealing with patients with soft bones, and therefore we have weak anchors. And so broad bending becomes very crucial. If we try to estimate the contour of the rod externally, it definitely does not match the internal contour of the rod. And when we try to persuade the screws using the built-in persuader system, it puts a very high stress on the screws and could lead to this complication, which is a screw backing out. So how do we overcome this? Is the use of simulation towers. We have modified this for one of the systems which we use in our center. But if you don't have these simulation towers, what you can use is to use ghost screws. Very simple, just place the percutaneous polyaxial screws or any polyaxial screws on top of the tower to mimic the contour internally. Second is the worry about the late implant failure, because as in posterior surgery, there's a lack of anterior column support. And nowadays we have a longer survival, particularly in the slow growing tumors, and improved adjuvant therapy, which increase the survivorship of tumor. Luckily, this is rare. The reason is with the improvement in the adjuvant therapy, it will also lead to bone formation, as shown in this report by us in 2016. And even with conventional chemotherapy, if the patient responds to the chemotherapy, it can modulate and cause bone formation. And therefore, the instability, which is because of lytic bone formation, will be reduced and the bone can become sclerotic. So in our experience, it is rare to have this rod breakage or screw complication in the later stage. So in conclusion, surgery is superior for MIS. Secondly, MIS approach would reduce the perioperative risk with similar outcome. Third, it is good to incorporate the norms framework to identify the surgical indication. Number four, survivorship prediction is just a guide, and often we need a multidisciplinary decision on surgery. And finally, with better adjuvant therapy, we must understand that there's an evolving landscape, and this would influence the survival as well as the stability of the whole construct in MIS. Thank you very much for your attention.
Thank you, Dr. Chris. Always a pleasure to hear. The gold school is quite good, I think, even for my MIS surgery for long construct. There is a recent trend to use carbon implant, and I think they are also developing MIS carbon implants. You use a lot of SBRT. Can share with us some of your thought processes for this carbon implant SBRT versus metal implant SBRT, and any difficulty in MIS?
Sorry, Dr. Wu, we are not so advanced. So in Malaysia, we are still using titanium implants. So we have not much experience in using carbon implants, but I do believe that overall it could improve the overall management of this group of patients.
Okay, then another question from Dr. Vijay. SBRT in the presence of implants, basic precautions not to hinder the SBRT in terms of cages, transverse connectors, implant proximity.
In general, because the delivery of the dose is not linear, it doesn't go through the implant, it can go around the implant. So there is not that much concern as to the positioning of the screw at a bone which is very near the tumor site. We do not implant cross connectors because the screws are inserted through an MIS approach. So, but in terms of placing the screw very near the tumor site, there is no problem with SBRT.
Let's see. How about the screws? I think, do you try to put the proximals just at the tumor level? Do you put the screw try to be a bit further apart so that you can see more, let the radiologist see more clearly on the anterior vertebral body?
Sorry, that means that we put screws which is
So
further
any
away from
screw
the...
consideration, because I think the metal implant causes artifacts, and then the radio oncologist may find it challenging to plan SBRT. So any screw considerations?
So far from our experience, the oncologist has not gotten back to us complaining that it's difficult for them to plan their SBRT. So I think that for them is still okay. As you can see from even from the MRI, so they routinely perform special protocol MRI just before the SBRT, and the titanium implant doesn't really cause that much of a artifact or interference with images, so they can still plan their SBRT accordingly, even in the presence of implants.
Okay. Dr. Chiki asked, besides adequate contouring, are there any other precautions when you insert the rod, especially in long construct MIS stabilization?
I think the rod contouring and rod bending is very important, because we want an in situ stabilization without causing any stress to the screws, because we are dealing, like I said, with soft bones and weak anchors. So besides that, when you pass the rod, it is very, very important to make sure that you are actually deep to the fascia, because in some instances, when you pass the rod, it can catch on to the fascia, and actually it can cause depression within the deep fascia in some cases. So this is something we are very careful when we pass the rod, to make sure that it's actually in the subfascia and it's intramuscular plane, rather than sometimes through the fascia or superficial to the fascia. So those are the additional things we look out for. But for metastatic spine disease, first and foremost, I think the rod contouring and bending is the most important.
And Dr. Park asked, do you incorporate medical treatments such as target agent into surgical decision making?
Not so much. As you can see, that what we use is a NORMS framework as the treatment algorithm, because the definitive treatment using targeted therapy would be a systemic treatment, and surgery itself is actually a local treatment. So these two are very separate entity, and therefore it is definitely, if we are going to incorporate targeted treatment, it is always welcome, but that is like after the surgery and in terms of the systemic control of the disease, rather than the local therapy.
I see. Okay. If there's any more questions from the floor, we're given an extra minute. Otherwise, we'll let Dr. Vijay Loya to continue the introduction.
Thank you very much.
Dr.
Thank you.
Next, I would like to introduce Dr. Vishal, sir, for his talk on minimal invasive treatment of thoracolumbar fractures. Dr. Vishal.
Thank you, Dr. Vijay and Dr. Wu. I hope I'm able to share my screen and my screen is visible. So MIS in thoracolumbar spine trauma, why, what, when, and how, these questions, I think most of the previous speakers have already laid the ground ripe for this. And the techniques have evolved. The success stories about the role of MIS surgeries in degenerative pathologies is extremely clear, as was highlighted by Dr. Arvind Kulkarni. The extension of MIS surgeries into thoracolumbar spine for, again, degenerative pathologies is also clear now. And also in cervical spine now, more and more of tubular techniques are evolving to deal with degenerative pathologies. Dr. Chris also highlighted about the success stories about tubular decompression methods and also percutaneous fixation methods in spinal metastasis. Thoracolumbar spine trauma is another pathology being dealt by same techniques using the principles of management of MIS, using various technologies of tubular technique, microscopic decompression methods, expandable tubes, expandable cages, and various modern inventions in implantation to deal with one different pathology, but same technique. Now, the biggest question is, why do we need MISs in thoracolumbar trauma? The answer to this is very obvious. thoracolumbar trauma in itself is more often than not associated with a polytrauma with multiple skeletal fractures, and very often than not a PLC injury, which in itself is an extensive injury. And these injuries happen only after there is a soft tissue and muscle disruption to a significant degree, which in itself is a catabolic state. And imagine adding the trauma of an open surgery to this is not only going to add to the morbidity of the patient, but other metabolic issues, resulting into a poor and delayed rehabilitation of such patients. And it is very well proven that the morbidity of this catabolic traumatic state only increases if an open or conventional surgery is used to stabilize these patients, not only because the blood loss increases in these patients who already have a hematoma resulting into a morbid situation, but the infection rate is twice compared to the degenerative pathologies when you're doing a conventional open approach in this, and it has been very well proven in multiple papers. Muscle-related morbidity in already traumatized muscles result into more post-operative pain and delayed recovery, again failing the primary need of surgery in these patients, which involves early rehabilitation in such patients. And that is why on one hand open surgery has stood the test of time, but there are ways and means of increasing, and there is a dire need of MIS surgery to play its role of benefit in thoracolumbar trauma. And it is not new, because the benefits of minimal invasive surgery in any kind of trauma, orthopedic trauma, is very well established. So why keep spine aloof from the advantages of MIPO or minimal invasive percutaneous fixation techniques? The advantages are pretty evident. The incisions go smaller, the muscle damage is less, blood loss is less, post-operative pain is less, and the very essence of surgery in thoracolumbar trauma comes alive when early rehabilitation can be started in these patients without compromising the actual efficacy of the surgery. Forget about the benefits in obese patients and in patients who already have a dural tear due to traumatic reasons, where again minimal invasive surgery techniques are not only forgiving but have added advantage of performing these. So these surgeries have an established role to play and should be tried to pursue whenever possible in patients with thoracolumbar trauma. The immediate clinical outcomes have proven that in thoracolumbar trauma, minimal invasive surgery is as equivalent to conventional techniques, if not better, when it comes to decompression, stabilization, and reconstruction, with added advantages of lesser morbidity due to infection, blood loss, and pain also. Again, the essence of early rehabilitation becomes alive when you do a MIS. More than in degenerative pathologies, it is recommended to do a MIS technique in thoracolumbar trauma, where it is more direly needed than in only degenerative pathologies. And evidence is full to show the efficacy, that it is working. It has shown to be beneficial, not only to patients with mild trauma like burst fractures, but also in patients with fracture dislocation. And even in damage control orthopedics, the role of MIS is very well established and should be strongly advocated. We all know what are the basic principles of surgery in thoracolumbar trauma. It basically involves any kind of surgery to improve the quality of life and early rehabilitation of such traumatized patients. And this can be done by reducing the impact of secondary injuries, by increasing decompression and clinical outcome, and by reducing the morbidity. And all this requires either decompression, stabilization by fixation, or by reconstruction. And all this can be easily done by tubular techniques, percutaneous fixation techniques, and now the newer kid of the block, which is direct lateral approaches, again can be done by expandable retractors. And with the expense of expandable cages, you can do any amount of reconstruction and corpectomies only using MIS techniques. And this not only posteriorly, but also can be done anteriorly as well by direct access. How do we do MIS? The principles remain the same. Dr. Arvind and previous speakers have highlighted how to do these surgeries. It basically involves going through the muscles without having to strip the muscles, sparing the multifidus and sparing the posterior midline structures, going laterally in the canal and doing decompression by pushing the retropulse fragment anteriorly or volarly using specialized instruments and tubular techniques, reducing the size of incision. Again, the principle is to reduce the axis-related morbidity, reducing the size of incisions, reducing the muscle damage to achieve all these what is required to get a good decompression reconstruction in such patients. And this can easily be done by as small an incision as 22 millimeter by using a lateral and far lateral approach, as has been proven to be very efficacious in degenerative pathologies. You just have to apply the same principle, same technology in a different pathology in a thoracolumbar region. And it can actually be called a TTIF approach, where it is transforaminal thoracic or thoracolumbar interbody fusion approach, where you can reach the middle column, which is retropulse, to push it down and achieve good and effective optimal decompression in such patients. Percutaneous instrumentation techniques is very well established. we heard Chris speaking about multi-level instrumentations. It can easily be done either by fluoroscopy-based methods. You can also do it in navigation, which has added advantage of reducing the radiation and is easily accessible in most of the centers. Not only single or two levels, but the instrumentation has evolved to levels where you can do multi-level fixations using percutaneous techniques, and the technology and the techniques are very well defined. The principles of percutaneous fixation are no different in thoracolumbar trauma as well. How do we do decompressions? You can do a decompression using tubular technique, either by a fixed tubular cylindrical retractor, or you can use expandable retractors if you are keen to do a corpectomy in a patient with burst fracture, or you are doing a reconstruction using expandable cages, which have made life very easy to expand, to not only do a wide corpectomy in patient with burst fracture, but also to reconstruct, particularly handy in lower lumbar regions where you cannot spare the nerve roots and you have to actually leave behind the nerve roots without handling them and achieve the same reconstruction to get the lordosis there, which usually cannot be done by posterior approaches. Now, when do we do MIS in thoracolumbar trauma? I think every fracture that comes across, be it a simple burst fracture without neurology requiring a stabilization for early movement, or a flexion distraction injury like a bony chance or a PLC disruption, can easily be managed by only posterior techniques. A fracture dislocation, which usually is associated with a rotational injury, again can be stabilized first, and then a definitive surgery of reconstruction and decompression can be done at a later date. And polytrauma for damage control orthopedics, again MIS techniques come very handy, can easily be done even in the last minute or even in emergency settings. Patients like these, where burst fractures, decompression is required, or reconstruction of anterior column is required, you can easily achieve by a posterior surgery. Some of the case examples, as I'm going to show in these cases. The first case here, a L4 burst fracture with bilateral L4 nerve root injury resulting to foot drop, was managed by anterior direct lateral decompression using expandable retractor and expandable cages, followed by posterior percutaneous stabilization. You can actually appreciate the size of the incision there, not only abdominally but posteriorly. You can see the morbidity was so less that this patient was walking the second day, albeit the foot drop didn't recover completely, but the patient didn't require any prolonged rehab program. Another patient with burst fracture but PLC intact, having a conus injury resulting to cauda-equina syndrome with Gaines level 8. Again, this is a fracture which requires anterior reconstruction, being a L2. This time we resorted to only anterior direct lateral approach and did a corpectomy followed by reconstruction, all anterior approach direct lateral using expandable retractors and expandable cages. You can see and appreciate the size of the incision. Again, patient was mobilized the very next day, very small incision, almost nil blood loss. And these patients again have a very wonderful result in reconstruction, decompressing it all anteriorly using MIS techniques. Another patient with burst fracture at L4, all done posteriorly, not only getting in your cage there to reconstruct the area, but also to restore lordosis by percutaneous instrumentation is all possible using the principles of percutaneous instrumentation and decompression using cylindrical retractor techniques by pushing the retropulse fragment, getting good neurological outcome in this patient. Another case example where thoracolumbar fracture in elderly patient, augmentation was done by indirect means using cement augmentation and percutaneous stabilization. This patient had no neurology, only reconstruction required by percutaneous fixation, and again wonderful results there. In flexion distraction injuries, where there is a bony chance or posterior ligamentous complex injury, again, the principle is to restore the posterior tension band. The surgery is simpler. You need better optimal stability to be achieved immediately to prevent the impact of secondary injury on the dural sac. And this is what can easily be achieved. Like in this particular patient, a bony chance with no neurological deficit, managed by a percutaneous stabilization of long segment fixation using modern percutaneous instrumentation techniques with the help of navigation technique. Another case example where multi-level fixation along with reconstruction was required, again done only by posterior technique. Decompression, this patient was done as a second stage, and then decompression achieved by tubular techniques. Another patient of polytrauma, just putting in screws up and down prevents the secondary injuries in such patients, preventing neurodeficit from happening in a patient who was nil preserved at the time of primary injury. This is something that is very handy. You can do it in emergency setting, allowing the orthopedic and general surgeons to deal with life-saving measures while stabilizing the spine to prevent secondary injuries to the spine during the primary surgeries of more evidence. So this is all proven. There are techniques which are already being established in degenerative pathologies, as highlighted by previous speakers. You just have to implement the same principles in metastatic surgery, as Christian mentioned, and also in thoracolumbar. You can extend the indications there, and you can get almost similar results there. Yes, there are limitations. Bleeding is one of the commonest problem in MIS surgery. In thoracolumbar trauma, it becomes a magnified issue, particularly in trauma when it's all vascular there. When you're doing a direct lateral approach, the muscle is frail and the bleeding is far more a trouble to control. And that's one thing that you should be really aware about. The learning curve is a little more steep compared to degenerative pathologies because the anatomy is distorted in patients with thoracolumbar trauma. The spine is more unstable compared to degenerative pathologies. So you may want to start with simpler cases, but you can easily climb this ladder if you follow a certain path there. Reconstruction challenges can be there because the case that goes in and expands inside may develop a pseudoarthrosis. That assumption is always there. The graft reconstruction in these expandable cases is always a matter of concern. To conclude, thoracolumbar trauma, though, is a moribund injury, but management principles are very simplified and requires either stabilization, decompression, or reconstruction, or all of them in one go. The primary goal in thoracolumbar trauma is to optimize the function and quality of life, which can easily be achieved by application of the principles of MIS surgery, which should become the standard of care more in thoracolumbar patients to reduce the morbidity and early rehab as the first principle in thoracolumbar trauma. Thank you so much.
Thank you, Dr. Vishal, for your talk. Right now, I don't see any questions in the chat. Dr. G-Kid wants to know, often dura tear is present with the neurodeficit. So do you repair it or you leave it as such?
So very nice question, Chi. I think it's a very pertinent thing and often daunts the orthopedic and spine surgeons about dural tear in MIS surgery. The best part about MIS techniques is because it leaves almost no dead space, you can actually leave the dural tears unrepaired without a fear of either converting them into fistula or any kind of any leak in the wound. The size of the dead space of muscle is so small that even unrepaired, they will just convert into a sealed pseudomeningocele in there. However, whenever there is a dural patch which has been rugged out due to trauma or due to a bony fragment which is pinching inside the dura, those are the times when I would use a dural patch along with the biologics to repair the dura. A suture method is not utilized. I have no experience into that, but there are these dural clamps nowadays which neurosurgeons often use for brain surgery for clipping the aneurysms. Those clips can actually come very handy to bring and approximate the edges of the dura, which I have used often.
So how do you reduce a displaced fracture using MIS?
Another very interesting question. The basic principles of putting in screws comes very handy here. A patient with fracture dislocation, very often they will come reduced the moment you position them. If not, and there is a facet jump, like it happens in cervical spine, if there is a facet jump and the dislocation is not getting reduced merely by presence of positioning at maneuvers, in that case, your tubular retractor should go and do a bilateral facetectomy on one side and on the other side as well to do a partial facetectomy. And just by doing a partial facet removal, your implants, tulips placed at a level, the moment you put in your rod, it just pulls back. It's like reduction of a listhesis, provided you have done a adequate and optimal release of the facets. And this can very well be planned and known well in advance. By your CT scans, if you see that the facets are locked and the dislocation is locked there, you will have to do a bilateral facetectomy using tubular techniques.
How do you decide how many screws you have to use?
I think we follow the same principle of biomechanics. In a patient with burst fracture without dislocation where PLC is intact, it is always one above and below and reconstruct anteriorly only if Gaines's score is above 8. Whereas in a patient with PLC disruption, it is always 2 above and below. In a patient where there is a fracture dislocation of severe nature of grade 3+, I would recommend 3 above and 2 below.
How do you try to go for an posterolateral fusion, or there's a question from Slido, or you don't do PLF in instrumented segments while doing your MIS fixation?
Another very interesting question. In these patients, it is almost impossible to do a posterolateral fusion, particularly in thoracolumbar level when you're doing more than 2 levels of instrumentation. It is impossible to add graft in the capsular or in the facet joint area, at least above the thoracolumbar area. However, for 1 levels where burst fractures, you can easily add in graft there. You are pushing in the fragment there. And remember, it is trauma. All the bone is surely going to unite and you don't necessarily have to fuse that area. But yes, these concerns are genuine if you're doing a multi-level percutaneous instrumentation adding graft is a concern. However, in my 12 years of practice, I am yet to see patients where we have done 2 level above, below, and the implant failure is yet to come across. So something is working for us.
Yes. There are a few more questions. Do you plan for an implant removal?
No, I mean, there is no planned implant removal till date. In young patients where we deliberately are doing only percutaneous fixation, like in a bony chance, we tend to counsel our patients that though we are doing a 2 level above below fixation and you have a bony chance fracture, we would want to remove these implants to get more agility of the spine. However, most patients, at least in this part of the continent, they are not very happy to get the implant removal surgery done. And thoracolumbar junction really doesn't poses any morbidity to them, even if 2 levels above below is fixed. Their flexibility is not gone. The stiffness of the spine doesn't increase. So the need to get an implant removal is yet to get established in their minds. We do counsel about it in patients with bony chance fractures.
Thank you, Dr. Vishal. That was an excellent talk. Now we'll go for case presentation from Dr. Wu Pak, who will be presenting about lateral lumbar interbody fusion. Dr. Wu Pak.
Okay, I will share my screen. I hope all of you can see it. Can you all see, Vijay?
Yes, I can see your screen.
Okay, so, okay, I acknowledge my fellow who prepare many of the slides. I have some conflict of interest. But this is an interesting case because this is pre-operative. I'm doing next week. I thought this is a very good opportunity to ask the expert opinion on this. I have a 63-year-old man. He's a fruit seller. He has a back pain score of VAS 8 for more than 5 years. He has bilateral calf pain of VAS 4. On walking about 500 meters, he gets severe back pain and he needs to sit down. It affects him because he's a fruit seller. He needs to stand up and walk and carry on his living. So it's affected lifestyle-wise. The neurology is normal. This is the scoliosis phlegm. And you can see that there is a convexity towards the left. And slight, I mean, it's pretty neutral, but slight coronal imbalance and sagittal imbalance as well. And we can see from the lordosis, there's some loss of lumbar lordosis. We calculated the gap score, which I will show later. Flexion extension don't really show any significant spondylolisthesis. There is a bony spar, and in terms of compression of the nerve roots, I think there is moderate to severe compression on the concave side. However, it's not that bad, so that's why the claudication is not the main factor. It's mainly the back pain. So these are the lumbar parameters, and you can see the SVA is 7. Due to the loss of lordosis, there's also a proportional gap score of a severely disproportion. And so we have the CT scan as well. Interestingly, over the concave sides, left side, there are some bony spur. Interestingly, it's right over the entry of the OLIF corridor. OC corridor. So these are the further planning of the screws. So maybe I will start with Dr. Park. Based on this patient, would you think that he's a possible candidate for OLIF? And what will be your plan for this patient, which is going to be operated next week?
Can I see the sagittal parameter again? Yeah, yes, thank you.
Oh, here, yeah.
Sagittal parameter. Yeah, yes. So I think main barrier to perform OLIF surgery is his huge osteophyte. This is very common to see huge osteophyte around disc space due to severe degenerative change. However, in most cases, we can remove osteophyte during surgery without injuring other structures. So I think I can perform OLIF surgery, multi-level OLIF surgery.
I can perform with the removal of the osteophyte.
Yes, and the osteophyte is interestingly right over OLIF. So maybe my question to the panel, how about the retractor position? So there was some question of my colleagues that this osteophyte may not allow the retractor to place directly onto the bone because of the osteophyte. What are your experience of this? Any of the panelists? Yeah.
With regard to retractor placement, I prefer use the Langermann retractor with the hand rather than the self-retractor. So in the case, it is very difficult to place a self-retractor with screws. So maybe the alternative technique is the conventional Langermann retractor.
Okay, that's a good answer. And then for L12, is there any trick or how do you tackle L12 when there's a rib there?
So OLIF is best indicated from L2 to L5 because the replacement. So if you perform L1 to OLIF surgery, you have to remove some distal portion of T11 or T12 ribs. And it is very easy to perform OLIF if you resect some part of a rib. So you don't have to enter the pleural space. You can lie in the retroperitoneal space, just cutting the rib. So it is possible to perform in L2 level. However, in usual case, it is the L2 interbody fusion is not required for most cases. So L2 from S1 will be okay. So L12 can be performed by posterior fusion or posterolateral fusion.
So for this case, I think all the panel, would you go to T10 or we are happy to stop at lumbar L1? What do you think?
See, for this patient, actually, you see, this patient, I would treat him conservatively as much as possible, because unless the leg pain predominates back pain, I won't touch this patient because he has so many degenerative changes. There is the evidence of dish here. And I'm not sure how happy he'll be with at the end of a long fusion.
That's a very good question. I followed him up in 5 years. I've dissuaded him, send him back to the pain specialist, and he come back and back and forth. It's 5 years. Yeah, so he really wants this surgery, but I think it's a very good consideration. So if we have failed the conservative treatment and convince him that this surgery, doing OLIF may not work, but he still wants going for it. Do your instrument to higher than lumbar, and what are your preference, and what are your experience on PJK in those cases?
So if he has an apex at thoracolumbar junction 5, 4, 3, 2, 1, 12, 11, 10, 9. So if you stop somewhere around 10 or 9, it will be again suicidal, because that will be exactly at the apex of his thoraco, the kyphosis. So again, he might come back after some time for an in view of an ESD. Then probably you'll have to acknowledge that and counsel him about a possible further surgery after all this.
Okay.
So in my opinion, I think regarding the fixation level, so lowest instrument vertebra should be pelvis. You have to fix pelvis because there are great risk of the L5S1 pseudoarthrosis because of long fusion. Even if you perform L5S1 interbody fusion, it is very risky for the pseudoarthrosis L5S1 without the pelvic fixation, such a long fusion surgery. So I think the lowest instrument vertebra should be pelvis. So in terms of the upper level, our principle is to avoid kyphotic level. So in the X-ray, you can see the thoracolumbar junction kyphosis. So I think the upper screws should be extend beyond the thoracolumbar junction kyphosis. So I will prefer T10 or T9 fixation.
Okay. Okay, thank you. So this is pre-op, so I will let you all know when we meet up. So this is another similar case. It's post-op, so can discuss more on this case. The accountant, active lifestyle, back pain, no leg pain, and then walk more than 10 minutes, and neurology is normal and failed conservative treatment. This is the MRI showing multiple level degeneration in the disc, and vacuum disc is apparent in multiple lumbar segment. But interestingly, her L5S1 is pretty pristine. This is her parameters in terms of sacral slope pelvic tube and lumbar lordosis, PI. And again, with this one is we discussed some of the issue just now. I think I wanted to ask the panel, what is your experience? Do you have cases of PJK in lumbar only OLIF? There's not much literature on that.
So I didn't get your point, sir.
If we stop at the lumbar fixation, are there any incidents of PJK? Personally, I felt that if the posterior ligamentous complex is preserved by indirect decompression, I think the incidence of PJK is low in MIS surgery. So in the panel, any of you have read up on literature and any experience on that or have different opinion?
So in my experience, see, I don't go usually beyond 2 when I do a MIS TLIF. I don't do OLIFs. But in open surgeries where I've fused till L3, I've seen a good number of patients, I can't tell you the percentage, good number of patients breaking it down at L2-3.
I see. Okay. So adjacent segment degeneration, yes.
So, and if you go by statistics, the highest would be, thoracolumbar junction, then the upper thoracic. About 15 to 20% of all which stop at thoracolumbar junction, they develop a PJK, and higher up around 8 to 10%. If you go to T2, T3.
So in the panel, what are your opinion on XLIF versus OLIF? Is XLIF really out of the favor now? Or I think there are some indication of XLIF. Yeah. Dr. Park, can you share with us? Do you when will you do XLIF?
Yes. Unfortunately, in Korea, we cannot use XLIF because XLIF is not available. However, we have the DLIF surgery by mentoring. I think DLIF and OLIF is the same procedure. Just the DLIF approach is through psoas muscle, and OLIF approach is anterior to psoas muscle. Same approach, however, same cage placement, same trajectory. So I think there is not so big difference between the XLIF and OLIF surgery. But however, I prefer OLIF surgery because of the neurologic damage risk in the DLIF surgery.
And for your OLIF surgery, do you do the top first or bottom first?
So usually from the I think from the bottom, usually from the bottom. However, if you start with from the bottom, it is some problematic. It can be some problematic the upper segment because of rib prevent the approach. So if we perform the if we go up to the L2 or L1 vertebra, I prefer start with the upper segment first because of rib problem.
And in terms of coronal deformity and surgical malalignment, what is your limit to MIS surgery, and what are the cases that you will prefer to do it open, posterior or anterior?
So, coronal deformity is. Can I see the X-ray?
Yeah. So, how much coronal deformity or surgical deformity would make you go do it open?
By open.
Yeah, open, like, T10 to pelvis with Smith Peterson or TSO, etc. I mean, I know we will study, and there was some thought about 30-degree coronal deformity and being the benchmark, but do you push the boundary and do it for a larger deformity?
So the correction amount will be dependent on the patient curve flexibility. So if the curve, if the flexibility is very high, you can make more lordosis using the OLIF surgery. However, in case of a stiff curve, it is a very limited correction power using OLIF surgery. You can consider some other cervical osteotomies. It depends on the patient curve flexibility in coronally and sagittally.
I see. Okay, great. So let's proceed on to C. I did XLIF for this case. I think main thing about DLIF and XLIF, I think XLIF is trademarked by Invasive. Of course, now they have been bought over by Globus, so they may change. But basically, they do with neuro monitoring of the EMG when they do the XLIF. Personally, I felt that the psoas corridor in this case, you can see that the psoas are pretty atrophic, and the OC corridor is huge, but the psoas is quite small and atrophic, and it's pretty easy to go. And it is pretty much an elephant type of psoas, not the Mickey Mouse type, and I think it's favorable for XLIF. I think certainly OLIF can be used as well. And then for the last part, I didn't take the rib. I did the endoscopic fusion, which is how I complete the surgery by MIS method. So this is the neural monitoring I talk about in XLIF. I think Dr. Park shared when we do OLIF, we don't need this, which I agree. And then this is how we put in the cage. I find that personally doing X and OLIF, I find that XLIF gives very nice horizontal cages, while OLIF, while we do orthogonal maneuvers, sometimes we don't have beautiful horizontal cages like in this view. What do you think, Dr. Park? Is it my technical issue?
Yes, very nice picture. Very nice picture.
Perfect horizontal cages, but in OLIF is a little bit challenging.
Yeah, right. Yeah. During OLIF surgery, we have to use the orthogonal maneuver, and then cage tend to be placed to posteriorly. So to place the cage more anteriorly, the entry point should be made somewhat anteriorly more. So put the cage more anterior side.
So basically, that's how we put in the screw percutaneous. How do you reduce radiation? Or do you do it using a navigation for your OLIF? How do you reduce radiation in this multiple level segment surgery?
So actually, I use in my hospital we have navigation ORM navigation system. However, I don't use ORM navigation system during OLIF surgery. I use just the C-arm. So during surgery, I don't use C-arm not so much. So for the first for the check level, I use C-arm, and then all surgeries performed by naked eye without serum.
I see. Yeah, with more experience, we can certainly do that. So yeah, the last part I did endoscopic TLIF, so just to avoid the rib cutting. So percutaneous screw, and yeah, so that's the X-ray. I think you look like the adjacent segment is going to break down soon, but I'm not sure. But the patient did very well post-op. This is the wound. I mean, this patient, I did it 3 years ago, and he's doing well. No adjacent segment yet. So this is the video post-op day 14. So she stays alone. That's why she went to a community hospital just for rehab. But she's doing quite well. Initially, she had some psoas irritation, so a bit of grade 4 weakness in the psoas, and then some numbness in the lateral thigh, resolved by 2 weeks. So, Dr. Park and the rest of the panel, what's your experience in this numbness in the thigh and weakness in the hip flexion? What's your experience?
So that is the reason I don't do OLIFs.
Okay.
So it is very common to complaining the psoas irritation, psoas weakness. However, in 100%, it resolved within 2 weeks.
Yes.
No problem.
No problem. Yeah.
Yeah.
So yeah, my longest one took, which I kind of struggle in that case of so she took about 6 months, but she completely recovered. I haven't had one, fortunately, that haven't fully recovered in terms of the thigh weakness. But the thigh weakness, I would say, is quite disabling. And although the wound healed well, they are very nervous. So am I. Luckily, so far, everyone healed. So I think we have addressed most of this issue in my sharing of case and earlier discussion. I think for me, I felt I think the pre-op counseling is important. I think the lateral surgery have big cages, fusion rate is very good. However, I have to counsel them about the extravascular risk, as well as thigh weakness and numbness possibility, which are addition risks not present in so much in MIS posterior surgery. I think maybe we don't break the table too much. Over break the table may tighten the psoas and make things more difficult. And then be efficient with experience like Dr. Park. We can even minimize your eye radiation and minimal retracted time, and certainly that decrease thigh numbness and weakness. Don't cut into end plates. And that takes experience. I think, Dr. Park, sometimes we do the extra X-rays to prevent cutting into end plates in very osteoporotic bone. So what is your trick if you don't do more X-ray so that you won't get this large corp into the vertebral body? What's your trick, Dr. Park?
So you mean, can you repeat the question again?
So because you mentioned you do a lot of this preparation without X-ray. So sometimes we may just get the corp into the end plate if we don't do X-ray to check. What are your tricks to prevent that?
Yeah. So I think the more important thing is not X-ray, but our feeling from the hand. The feeling is very important. So don't trust the X-ray. Don't just trust your finger feeling more.
Okay, certainly. I see. I always have a PLIF, TLIF sets available. Okay, thank you. I think for MIS TLIF, maybe this for panel, everybody, for deformity in MIS TLIF, which is one of the limitation. What are you thinking? Certainly OLIF and XLIF, we find that correcting deformity can be quite a plus. And what are your tricks in MIS TLIF deformity correction?
I think MIS TLIF is a very limited role to correct deformity. It is a very best indicated for sure 1 or 2 level shear fusion. However, during posterior surgery, with the posterior surgery, it is very limited role to correct sagittal balance without surgical lumbosterotomy. So I think posterior interbody fusion, TLIF or PLIF is less effective for the correction of deformity.
Dr. Arvin, would you want to discuss about that?
Yes, so as I said, I don't usually go beyond 2 levels when I do a MIS TLIF. So the degree of deformity correction would be for a local listhesis or a very segmental scoliosis. In fact, even in a degen scoliosis, I would hunt for a level, wherein I could just do a selective fusion. Otherwise, if it is a long deformity that needs correction, adult spinal is generally open.
Okay. Yeah, I felt that the OLIF gives some option to that, maybe an alternative. For those less than 30-degree curve, I think it is a good option for the patient. Certainly, it takes a bit more surgery, a bit more implants related like BMP or so. So these are the discussion that we need to highlight to the patient. Thank you for all the participation.
Thank you.
I don't see any questions in the chat. I think we can move on to the next case if there are no further questions. Next case is non-union after MIS, and Dr. Yong from Malaysia will be presenting it.
Is Dr. Teo Yen Yong?
Yeah, I'm waiting
Okay.
for the other side to upload. Yeah.
Okay, thank you.
It's a pre-recorded presentation. Hello, can you hear the presentation?
I think you need to share the sound too. I'm not sure why no sound.
Yeah. Okay. Never mind. There's supposed to be sound.
Yeah, we can hear you. You can start from the first slide.
Yeah. Okay. All right. He also.
Oh yeah, we are hearing the sound. Can just like make it louder maybe.
Also has got a reduced L5 power, which is 3/5. The rest are normal. So we proceed with action. And the listhesis will reduce slightly on extension view. MRI examination noted that he has got a severe central canal stenosis over L4-5 due to bilateral facet hypertrophy, thickened ligamentum flavum, also due to slight protrusion of the L4-5 disc. L3-4 and L5S1 canal is also moderately stenosis. So we planned for 2-level MIS TLIF for him. During the operation, 6 guide wire were inserted from L3 to L5 bilaterally. After that, complete facetectomy was done at L3, L3-4 and L4-5. This was removed and the end plate was cleared as clean as possible. We insert 2 cage, size 12 × 21 mm with DBM inside. Then subsequently we insert 6 screw, size of 45 mm × 75 mm. Both level of screw compressed before the nuts were tightened. So this is the X-ray post-op, which can see that the conversion of the screw, the positioning of the cage are satisfactory, except for L4-5 cage is slightly posterior than we expected. But however, after the operation, patient was quite satisfied. He has less numbness. He can walk longer than before, and then the L4 radicular pain is no longer there. But however, after 5 months of post-op review, patient claimed that he had got a progressively worsening back pain. He was unable to walk far due to back soreness. He also complained of mild radicular pain over the previous left leg. But there's no fever, there's no loss of appetite. ESR, CRP, and white cell count are all within the normal limits. So we did an X-ray and noticed that the L4-5 screw were actually dislodged and back off. There is a lucency between the L5 screw. So we proceed with the CT scan and noted that the L5 screw is actually loosened. However, the good news is that there is no end plate erosion at the L4 and L5 end plate. There's no fracture as well. So after discussing with the patient, we decided to go in for revision surgery. During the operation, we did a half turn over L3 and L4 screw, and it was tight, so we keep it. We did not change the L3 and L4 screw. However, the L5 screw was completely loosened, and we changed the screw from 7.5 mm to 8.5 mm diameter, length from 45 to 55 mm to help us to get a bicortical purchase for the L5. We also use a bigger cage, which is 13 × 26 mm. Also, then we applied DBM inside, and we insert 2. Before we close, we actually do an intertransverse process fusion by decorticating the L4 and L5 posterior cortex of the transverse process. Then we applied BMP over L4 and L5 transverse process. Some of the disc material were removed, residual disc material were removed, and the tissue from the pedicle screw tract L5 were taken for culture, which of course it is negative. Gram stain also shows no organism seen. This is the X-ray taken immediately post-op. You see that the space of the height of L4 and L5 is increased. You can see there is a bicortical purchase of the L5 pedicle screw, which the tip is the tip of the L5 screw is beyond the anterior cortex of the L5. The lordosis is also restored. So after patient was discharged, day 2 post-op. Upon 3 months follow-up, there is no more back pain, and there is some residual discomfort of a left lower limb. So our plan is actually to review him every month, just to make sure the screw is not loosened. Thank you very much.
Okay, so in this case, other than going back from posterior, any other option that you guys would suggest? Because I'm a posterior surgeon, I only do everything from the posterior. I'm not familiar with OLIF or XLIF, so that's my only option. If it's your case, what would you do otherwise?
See, the thing is, you are lucky here. You're able to put 8.5 screws. In India, 8.5 screws are not available, and here again the screw, the loosening around the screw is quite significant. So in case you're not getting a purchase, you're not very happy about it, I would have gone to L5, because anyways, probably this patient might develop L5 S1 related symptoms later on, because it's quite stenotic. So
Yeah.
there is a reason to go to S1 apart from what you call bailing out the current problem. So that is justified. So I'd have gone to probably L5.
Yeah, you mean S1?
Sorry, S1.
Yeah, I do consider that as well. But luckily, we got a better purchase. I mean, we can get a good purchase on L5 after revision, so we just stop at L5. Would you do an OLIF for that? I mean, take out the cage from behind, go to the front and do OLIF?
So since you're lucky that it was all posterolateral, it was coming out just like that. That is the advantage of TLIF. So it's usually a diagonal insertion of the cage.
Yeah.
So I've had such an occasion. So in this, I put BMP inside the cage.
I have experience of putting the cage with BMP. Patient have a lot of irritation, nerve irritation. They won't feel
that's the possibility.
Happy about it for few months. Yeah. So I stopped doing that. So I just do a intertransverse process fusion. Usually it works quite well. This is my third case in 2 years or 3 years of revision such patient.
When you revised, did you do that in open or did that?
I use back the old incision with UC approach. So it's mostly like a mini open technique. I don't use the tube anymore.
Oh, I see. Okay.
This is a mini open technique.
So macular kind of retractor or some kind of
just normal
long retractor. Okay.
Yeah.
I think the cage back out posteriorly. So unless there's a lot of bone loss, I think I would still go from the posterior. Of course, certainly, if we want to increase the lordosis or we want to put in a large cage, then I can go for OLIF as well. I think in this case, the cage is already back out. We just use back the same track, and probably is the less invasive and easier way. I think the posterolateral fusion is a good choice. Yeah. Sometimes I do this endoscopically if the cage is really good to take out, and then I can punch the cage horizontal using the scope.
Yeah, but how about the screw then? If you use a minimal invasive again, how about the screw?
Yeah, so the screw can use the old arm to guide a new screw with a new track. Taking out a set screw rod from the scope is not difficult. In fact, quite good. You can see the set screw very clearly. So we can do that under biportal endoscopy. I think doing uniportal endoscopy for this fusion revision will be challenging. So I will do that with biportal.
Yeah, I think I can't imagine the difficulty of using that endoscopic surgery.
But if the cage is just back out slightly, then we can actually do, if we want to do scope, can use the scope to just push back the cage more horizontally. And but I think ultimately probably the screw loosened. That's why the cage back out.
Yeah.
When you change the loosen the screws, my tip is put the allogeneic bone graft to the screw hole, hacking bone graft. Then you can make a new trajectory with the bicortical purchase, and you can feel very tight screw purchase. Yeah, packing the allo bone graft.
Yeah. But I think the difficulty for this patient to get a new track is that it's already quite a big screw for my population here is 7.5. So if you're going to redo the direction, then the so-called pedicle will not have enough space for you to do that. You become from a single hole, you become like a binocular hole like this. I tried before, then you will lose. You won't get a good purchase over the pedicle. If you know what I mean, it become like this, two hole. Any more questions?
I think no more questions.
Okay, I'll pass it back to the moderator.
Thank you, Dr. Brian.
Yeah.
Thank you, Dr. Brian, for your case presentation. Yeah. So I would like to hand over the session to Dr. Vishal for his summary statement and vote of thanks. Dr. Vishal.
Dr. Vishal, please unmute yourself.
Thank you, Dr. Wu and Dr. Loya, for conducting the session wonderfully, bringing out the most important aspects of minimal invasive spine surgery in these 120 minutes, where we went on to discuss about the basics, the principles and techniques of minimal invasive spine surgery, including the tubular techniques involved in degenerative spine, involved in anterior direct access oblique lateral views by interbody fusion and techniques and pitfalls. We also had a wide approach to use of these techniques in metastatic and thoracolumbar trauma, and wonderful case discussions by our case presenters brought about the nitty-gritties, the problems and challenges that a regular audience involving into MIS surgery will face. These 120 minutes are just a beginning about the advancements in spine surgery. Minimal invasive spine surgery is only one aspect of minimal invasive, one aspect of advancement in spine surgery, and I'm sure in the coming months, Asia Pacific Spine Society will bring forward newer and newer webinars through the aegis of APSS to further deliberate upon interesting topics like cervical spine, craniovertebral junction, and many more. The Advanced Spine Webinar Series of 2023 involves 4 such webinars in this year, 3 such webinars more to come, and also the Basic Spine Webinar Series of 2023 is also going to come every alternate month to highlight upon the basics of spine surgery. Both these webinar series under the aegis of Asia Pacific Spine Society are meant to spread the knowledge and create more education and deliberation upon spine surgery for all the young and the wise guys. We look forward to your active participation in all these webinars, and for more details about the Asia Pacific Spine Society Spine Webinar Series for 2023, please log on to the website of Asia Pacific Spine Society. I also urge all the delegates who are attending the webinar series to please visit the website of Asia Pacific Spine Society and see the benefits of becoming the member of Asia Pacific Spine Society, which is not only growing rapidly in the whole Asia Pacific region. We are more than 600 members already in the whole Asia Pacific area from 27 countries, and it's growing faster. More and more members are joining in, contributing to the development of Asia Pacific Spine Society, learning from it, and also having added advantages of being a member. There are a lot of member-only privileges for life members, which includes reduced registration rates to all the APSS meetings, right from the north of Japan all the way to the south of India, and ranging all the way from the east in Australia and west all the way to the other parts of Asia Pacific. There are opportunities to apply for fellowships, which are paid fellowships in various regions, including Hong Kong, Malaysia, Philippines, Australia, India, and many other countries which have many APSS fellowships to offer for all the members of Asia Pacific Spine Society. There are many other journal access, academic meeting access, and free subscription to journals of Asia Pacific Spine Society available only for the members who become life members. Try and go and visit the Asia Pacific Spine Society to see all the academic activities happening under the aegis of Asia Pacific Spine Society, and the membership comes for a mere cost here. Life membership is something that is you must try to get into. We look forward and welcome you all to the Asia Pacific Spine Society to join as the life members of APSS. Through this spine webinar series, which are going to happen at a regular interval, we look forward to spread the knowledge from various parts of the Asia Pacific part of the continent to all the members who visit and view these webinars. With this, I take the opportunity to thank you all for being with us for last 120 minutes on the deliberation of MISs in spine surgery. I also take the opportunity to thank all the wonderful faculty for the deliberations they made on this amazing topic. And I'm sure we all had so many more points to learn apart from teaching the youngsters. Looking forward to your participation in the upcoming webinars. With this, I wish you all a happy Sunday today and forever. Thank you so much. OrthoTV, you require a special mention of thanks, and we really applaud your efforts to relay it to the far-fetched corners of Asia Pacific. Thank you, OrthoTV. The secretary, Jennifer and Kelly, have been working effortlessly, and they have been really making this whole process smooth. Thank you, Jennifer, and the whole secretary team at the back end. Thank you, everyone.
Thank you.
Thank you. Bye-bye.
Thank you.